Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. Today, I'm going to continue with the other uses for the newly introduced immunohistochemical stain, the H3K27me3, and this time is in posterior fossa ependymoma. This is a case of a 4-year-old male patient with posterior fossa mass, and as you can see, it's really a highly cellular tumor with hyperchromasia, foci of necrosis, and a tendency for perivascular arrangement, or what we call the pseudorosette. So it really is reminiscent of ependymoma. Now, on higher power magnification, and again, you can see the acellular or anuclear fibrillary zone surrounding the vessel that is showing microvascular proliferation. And then we have here the arrangement of the tumor cells. Now, in order to prove this is ependymoma or not, we have first of all to perform some immunohistochemical stains, and we start always with the GFAP, and the tumor cells are strongly diffusely positive. But remember, as I showed you in a previous video, GFAP can also be utilized to highlight the negative staining of the microvascular proliferation, as well as really it beautifully illustrates the tendency for the palisading around the blood vessels. So in a way, this is more supportive of ependymoma. Next stain is the EMA or the EMA, which tends to show cytoplasmic dot-like positivity, in the tumor cells, and this would also support that this is ependymoma. OLEG2 also is of utility because we have to see negative nuclear staining in the presence of scattered positive internal control like the endothelial cells. And then, since this is a posterior fossa ependymoma as shown and supported by the immunohistochemical stains and the morphology, we have to perform the H3K27 trimethylated. Why is that? Because as per the WHO classification, posterior fossa ependymoma now is divided into type A, an aggressive type, and type B, a more indolent type. Now, to differentiate between both, we have to do this stain because in type A, there is loss of the nuclear staining in the presence of internal positive control. Again, remember, this is important in terms of the prognosis because the posterior fossa ependymomas showing the loss of the nuclear stain tend to be more aggressive than the ones in which there is a retention of the nuclear stain. So essentially, the final diagnosis of this case would be posterior fossa ependymoma type A. I hope you find this video or this tip useful in your daily practice. Thank you.